Okay. So again, to go over what we'll be addressing is at the end of the session, hopefully all of you will understand the concept of anabolic competence and why it's the basis of everything we're going to be talking about today. To understand the rationale and the specific components of this assessment tool. And then before you leave today, we'll actually demonstrate a few things on perhaps one or two of you, but also be able to do a patient assessment on 3 of the patients that you're actually going to be the scoring and seeing how well it works. Now, in terms of the concept of anabolic competence, it's really a paradigm upon which almost everything that I do on a day-to-day basis makes a difference. And I think when you're taking care of patients or when you're seeing someone in your family who may have a medical issue, these are the things you have to address. And so all of us who are in the nutrition field tend to think about, well, if they're malnourished or they're at risk of malnutrition, I think about nutrition. But that's not all it is. So it's really optimizing and taking into components the nutritional milieu of that patient, exercise or physical activity of the patient, and making sure that the hormonal milieu is optimal. If somebody's hypothyroid, you're not going to be able to put muscle mass on them. If they have low testosterone levels because they've had a prostate cancer and now they've had some hormonal manipulation of that. So it's only when you take all 3 of those components, and the Venn diagram that we all learned about a long time ago, it's only when you combine all 3 that you really get optimal body composition and physiologic function. And that's really what we want for any of our patients. And for those of you who think that healthy living and healthy nutrition is also important. So it's really all the basis of that. And some of you have seen the short form of the PG-SGA. It's these 4 boxes. We'll talk a little bit about how that's developed. Again, I think it's important to know how we got there and how it's evolved. As I mentioned before, this is what it originally started out. The things that are in yellow are things that we added to the SGA, which was the University of Toronto tool. Theirs didn't look exactly like this, but we thought, let's take this in a way that's easy to fill out, but that addresses things not just about the weight loss of the last 6 months. Because if you've lost a lot of weight 6 months ago, but now you've seen a dietitian and you stopped losing weight, or you've actually started gaining weight, that's important of understanding anabolically what's going on in the body. So they took weight and weight history, what their diet intake was. They only looked at GI symptoms because a lot of people think of nutrition as only a GI process. But there's a lot of other components that go through there. So we took mucositis, dry mouth, taste changes, constipation, pain, smell changes, and eventually actually added to that also. The functional status, there's a thing called the World Health Organization or the Eastern Cooperative Oncology Group. They're the same assessment, but address aspects of functionality or activity that have actually been shown in a number of different settings of being predictive of how people tolerate therapy, how long they live, what their survival is, etc. So it's something that's a validated tool that gets used a lot. And what we actually subsequently did is put it in patient terms, so the patients actually report what it is. What's interesting, do you think as a dietitian, or if there's any nurses in the room, that you get a better idea when your patients talk to you than the doctor does? Who are you going to share more of the really important information? The nurse or the doctor? Nurse, dietitian, or doctor? Nurse or dietitian, because again, you're talking about if you're seeing the patient in a nutrition, you're asking about what happens in their life. What are they eating? You may get to know them and their family much better. And so the reality is they've actually done studies that show that the ECOG performance status, which is very predictive of how patients do, doctors rate patients much better than they actually probably are. And nurses and dietitians probably are much closer to what the patient has their self-report is. Because doctors want to get the patients on the clinical trials. And they can't get them on unless they're a certain level of performance status, because we know that patients who have poor performance status drop out of trials, die early, etc. So again, those are ways to put it in the patient terms. Then their disease and what their physical components are. Again, whether or not there's evidence of loss of subcutaneous fat, muscle wasting, etc. And we'll talk about that in a lot more detail. This was first published in an unscored version in 1994, so even before that 20 years. But we took a good idea and made it better. Simple idea and put it in patient terms. So one of the things that, as Harriet mentioned, I was at the Fox Chase Cancer Center in Philadelphia. now related to Temple University. And basically, we looked at this idea of a score, and we looked at 186 consecutive patients who were referred to the nutrition clinic. The average weight loss at the time of referral to the nutrition clinic was 16.8%. Is that early intervention, preventative intervention, or is it really almost malpractice? To think that patients aren't being referred to nutrition until they've lost almost 20% of their weight, which if we look at prognostic components is considered severe weight loss and associated with increased risk of death, and not even taking account how quickly that happened or how short that happened. That's really a very severe weight loss. So what we did is looked at an interdisciplinary intervention that was looked at standardized nutritional assessment, which was this tool that we were in the process to develop, aggressive symptom management, individual nutritional counseling, oral nutritional management. 100% of these patients were all done by oral intervention, an exercise recommendation or a physical therapy consult if they needed it. What's interesting is despite that nearly 20% weight loss, 50% of the patients stopped losing weight and improved their visceral protein status looking at prealbumin and transferrin. But obviously those people who'd lost that much weight were more at the end of their life, some of them, than at the beginning of their life. And so what we found is if we took away the people who had, in terms of the data, at least a 6-week life expectancy. So they're still kind of maybe, at the end, but they weren't immediate. And so if we looked only at the people who had at least a 6-week life expectancy, 80% of those people we were able to get to stop losing weight. Now think of what happened if they'd sent it to you all or your colleagues 6 months earlier, 3 months earlier. Do you think that would have made a difference? If we can take patients who've lost that much weight, and by doing an interdisciplinary approach, we get 80% of them to stop losing weight. And stopping losing weight is the first step to getting back into anabolism, to get better. And so I think this is the goal with very simple ways. It's not TPN, it's not tube feeding, it's all of them enteral. What was really scary about this, 5 of these 186 patients had feeding tubes in them when I did a physical exam. And I said, why aren't you using that? And every single one of them said they put it in at the time of the surgery in case I needed it, but nobody told me how to use it. You put feeding tubes in, you use them, especially if you're going to refer them to the nutrition clinic and the patients continue to lose weight. So there's a lot of things that you all will be the experts at in nutrition. And you have to know to speak up, to raise the issues, et cetera, and it makes a difference. So you saw that unscored version from 1994. This one here, the long version, basically was how we did it originally. We took the 4 boxes, we put them in a way that was pleasing. But one of the things is patients who are going through chemotherapy or are older, or as you can see by my head, I need my readers. The bottom line is this was actually very small for people to fill out, for the patients particularly, but also the nurses and the dietitians and the physicians. So we had a group up in Canada who said, well, I went up to give a talk and they said, well, do you like this? Is it okay if we use it? We've made it bigger so that these 2 forms are divided into this is the front and this is the back. I said, sure, it works. One of the things that's been an important part of this good idea with simple concepts is that you listen to people and see what actually works. And so it actually evolved into what we, for a long time, called the big print version of the PG-SGA. And then over the last probably 3 to 4 years, people have actually been addressing, maybe it's going to take longer to do this whole thing with physical exam and other aspects. Let's just take these first 4 boxes. Well, one of the things everybody thought, that was really cool. That was an idea that nobody thought of. Well, we actually called this part the short form. And when we developed it, we put 80 to 90% of all of the scoring here because we knew that clinicians were not always going to have time to do the physical exam and all the other aspects on the back. So when we did it, if you have a good idea, make it as simple as possible. Do it in a way that people can relate, but then take in the reality of the world. People aren't always going to do what you think they should do. So make it so that if they can't do the rest of it, you kind of snuck it through them. They're already doing 90% of the work, and the patient is filling it out, so they're doing 90% of the work. One of the things that we found is a lot of times having the patients fill this out in the clinic while they're waiting. How many of you have ever gone to a doctor? Now, if I don't see hands come up on that one, I know that it's a very shy group. Okay. How many times does a doctor's schedule run on time? Never. Okay, now we're getting some interaction. That's what I like. So if you've got a patient and a family where they're losing weight, where they're having pain, where they're not being able to eat, because you're eating, right? That's part of your life. It's how we interact. Let's go down and have a cup of coffee. Nutrition's an important part of life. And a lot of times if physicians or healthcare systems are not addressing life, are not addressing nutrition, and you're running behind schedule, that just ticks people off. I got 6 months to live. Why am I waiting all this time doing something that's not important? If you have them fill out the form while they're sitting waiting, they're giving you all the information you need. As soon as they come into the clinic, you can say, I see you filled out this form. Let's see what you identified as problems. You're doing something that they think is important, and it actually utilizes that time, and it actually streamlines patients' care. So this is what we did in terms of our initial design. Now this is we're getting into the 21st century. This is actually the multilingual app. The first language was Dutch. We now are working with a number of global, regional and language networks. Soon we'll have on a European Portuguese, a Brazilian Portuguese, Norwegian group. We're working with a group in Thailand, Farsi. We're doing things from all over the place that will actually now, hopefully, within the next year, have a multitude of language versions that will be available as paper versions, so if people can't do a high tech, but also on the app, and we'll talk a bit more about that. If people want to know more about the PG-SGA, about the app, about the bibliography of the approximately 160 articles that have to do with this, if you go to www.ptglobal.org, this is all there. One of the things, I don't tweet. This woman over here tweets. We actually have, we tweet, we have a YouTube a chat and Facebook. So this is something that truly I think is going to help this grow in a very, very big way. So now to understand kind of what the basis, the reality. We've been talking about PG-SGA, but I don't think you all, since there weren't a lot of you who raised your hands in terms of necessarily knowing it ahead of time. Although I hear there was some homework, wasn't there ahead of time? Okay. How did so few of you know about the PG-SGA if you did the homework? Let's say that again. How many of you heard about the PG-SGA before you came in? Okay, it's getting in the right direction. But to now understand the history of it. Now, some people say, why did you call it Protocol 9601? It's always nice to know where people came up with things. It was part of a clinical trial that we did as part of the Society for Nutritional Oncology Adjuvant Therapy, or KNOW-IT. It was the first study that we did in 1996, so that's where it came from. And basically, these were the clinical trials group. You can see it was largely people who had a nutrition background. My PhD is in nutritional sciences. And then we also had people who were statisticians. The specific aims of the study were to check the feasibility of utilizing this scored version in terms of ease, cost effectiveness, and applicability, to validate the scoring and the triage that we determined might make sense. And one of the nice things is we had people who were involved in oncology, medicine, and nutrition. So if it made sense from somebody in nutrition but didn't make sense from a medical standpoint, it was that interdisciplinary thought process that made a difference. And then to understand the patient distribution by category, to then look for quality improvement, national, international database. Right now, in terms of the PT Global, we're not collecting the data, but again, our long-term goal is to have a central repository, so we may have thousands of patients where we can understand what's going on. We developed a volunteer research network. The nurses and dietitians predominantly were part of this. When I did a lot of lectures, people would come up, Faith, this is so exciting what you're doing. Here's my card. If there's ever anything I can do to help you. And so I collected cards for a number of years. And then when we wanted to do this, I said, you offered to help. I'm now collecting. And so we actually had 55 institutions that were part of this. And what's interesting is that over 90% of the investigators for this were nurses and dietitians. Not anyone got paid anything. It was truly a labor of love and a volunteer network. And that's really been kind of what's happened with the PG-SGA and actually the PT Global, that it's people who passionately believe in this and are willing to do it. In terms of our pay, we developed the protocol, the IRB or ethics board package. This was the first time a lot of the nurses and dietitians had ever gone and presented in terms of an ethics board. So it was part of a paying forward for them also to really understand what it was like to be part of a clinical trial and present their idea. We looked at it outpatient and inpatient setting. It was all diagnoses. We were not exclusive for oncology, although that was my personal interest. We actually had about 300 patients who had renal disease, about 128 who had end-stage renal disease and were on dialysis. They had to be at least 18 years of age. When we started out, it was in English and Spanish, but then we ended up having a group in Montreal, so we actually also had a French translation. They could either be new or ongoing patients. We only asked that they do 100 consecutive patients, and we're looking at requiring only one evaluation to see how the patients scored them and how they scored them. Now, one of the things that's important to do is don't reinvent the wheel. If oncologists, and again, where my interests were, if oncologists grade everything 0 to 4, why should you come up with 5 points? If they're used to doing everything at 0 to 4, use 0 to 4. So 0 in oncology means minimal impact or no symptoms. 4 points means potentially life-threatening. So 1, again, easy way, 1 is mild, 2 is moderate, and 3 is severe. So thinking it from a nutritional standpoint, this was minimal impact on nutritional status or risk. So again, use what's familiar. Now, when we did the original triage, this has evolved. This is what we first tested to say that 0 to 1 had no intervention, a score of 2 points, needed education by nurse or dietitian with pharmacologic intervention. 3 to 8 absolutely required a dietitian with interaction, again, to take care of symptoms as appropriate. And that 9 or greater was important, and there was a critical need for intervention. You couldn't wait any longer to have somebody, whether that was oral nutrition, parenteral nutrition, or other aspects. Now, looking at this, as I mentioned, we had 55 institutions. We had 2,150 patients who were put on the trial, most of them within a 6-week period, all of them within a 6-month period. If you work with oncologists or you work with other clinical trials, this is an unheard of ability to recruit patients, again, because it was the passion of the people who were involved, and that we were asking them to do fairly simple things. About 80-20 rule, about 80% of them were outpatients, equally divided between men and women. What would you say is the average age of people who have cancer? What do you know about cancer patients? You get some little kids, but the majority of cancer patients are probably 50s to 70s. Okay? Well, that's what we got, that about 3/4 of our patients were representative of that patient population. But we did have, in the renal patients, people in their 20s, and we actually had people in their 90s, so we had a broad spectrum. We didn't say that they had to be malnourished, but we did find that about 40% of each gender had a BMI that was less than optimal, but 18.5, which is obviously abnormal, to 25. And that basically the breakdown of that. So again, if you remember this in terms of, this is only looking at weight. It's looking at no other parameters of nutrition, but simply BMI and addressing weight. In terms of about half of our patients had cancer diagnoses that are included here. Again, as I mentioned, we had about 6% that were end-stage renal disease patients who were under dialysis. So we had a broad spectrum of cancers. Do all cancers nutritionally have the same impact? Lung cancer, bad one in terms of nutrition. They have bad nutrition to begin with lots of times because of their risk factors. There's chronic COPD, etc. Pancreatic cancer, good or bad in terms of nutrition? Bad. Why? It's the core of how we absorb nutrients. So if I don't have pancreatic enzymes, and my doctor is telling me to have high-calorie, high-fat food, what's going to happen? It's going to go right through me. So again, that's where that interdisciplinary communication comes. What about breast? What happens to the nutritional status of most breast cancer patients? What happens to their weight? Let's start there. Yes, about 50% of patients will actually gain weight during the time that they're undergoing treatment. Lots of reasons. Lots of times they don't have tumor left. For postmenopausal breast cancer, obesity can be a risk factor. Okay? If I'm nervous, I've just been given a cancer diagnosis. If I'm heavy, do I eat or do I quit eating? Heavy people, God didn't make us right. It would be really nice if heavy people, when they got nervous or anxious, quit eating. They'd lose weight. That might be good. Thin people, if they got nervous, would start eating. They'd gain weight. That might be good. The reality, though, is it goes the opposite direction. If I deal with my concerns by eating, and cancer, breast cancer diagnosis is a concerning thing, I might actually eat more. People also learn with certain kinds of chemotherapy, if they nibble, they don't have nausea. So there's a lot of things that go into it. But just because I'm gaining weight, if I'm fatigued and I'm going for radiation therapy and I'm not doing things, can I lose muscle mass? So what's interesting is a lot of times people will look at women and say, with breast cancer, and say, well, they're gaining weight, but that's okay, it's not a problem. But they're not addressing the fatigue and the lean tissue loss, et cetera, and we'll talk about that. When we looked at in the last 6 months, we noticed that in the last 6 months they'd lost about 3 kilograms, or about 3% of their weight. In the last month, it had been unchanged statistically, but they'd still lost a bit of weight. But it's really the 6th month that was where we saw it. But what happens, again, if we'd gone 6 months, 1 month, you'd seen a dietitian and now you're gaining weight. So knowing what's happened in the last 2 weeks is also important. So what we looked at is we found that of the patients during the past 2 weeks, patients said about 1/3 of them had decreased in the last 2 weeks. About half of them had not had a change, and about 17% had increased. So again, it's not just what happens a long time ago, but what's happening now that helps me address what's anabolic and catabolic. Compared to my last month, what have I been taking in? And so the patients would say about 1/3 of them, less than, no change. Remember, those percentages are darn close to what we just saw in terms of what had happened to their weight. So if their intake and weight are very nicely correlated. But what happens if I'm 65 years old or 80 years old and I say I'm taking less than usual? That's the question my doctor asked me. I say, yes, I'm taking less than usual. What if I've been taking little amounts for the last 6 months, which a lot of geriatric patients can be doing? So I might say no change. The last month is no different than 2 months ago, is no different than 6 months ago. But we actually asked, what are they taking in? So of the patients who checked it was unchanged, 16% said they were taking very little of anything. Of the patients who said less than usual, 1/4 of them said they were taking very little of anything. So we later on added some additional components to include parenteral nutrition, enteral nutrition, and a few other variables. But for those people who said less than usual, 2/3 of them said they were taking very little solid food, 6% only liquids. What's interesting is the one that's the biggest category, other than taking little solid, is 1/4 of them saying, I'm just not taking anything at all. So lots of times when we're asking our patients questions, we're not asking what we think we're asking. They're listening to the question, they're answering what we're asking, and it's really not what's behind us in our head. So we really need to be careful, and that's why this type of tool can be very helpful in getting that. What's interesting is we actually also ask them about nutrition impact symptoms. Now, clearly this group probably realizes that smell and taste make a difference in terms of what people's appetite is. But a lot of doctors, for example, don't think about dry mouth and the impact that that may have in terms of people eating. Clearly we know if you're vomiting or you're nauseated, you're not going to eat. But a lot of times people don't think, if I've just had an enterostomy, I've had a bag placed, and every time I put something in my mouth, it comes out my bag as a patient. Until I learn how to deal with that, I might just quit eating because it doesn't come out the bag. So understanding constipation, diarrhea, mouth sores, all of those things. What's interesting is, remember, these are patients, 2,100 of them, a lot of them who had weight loss. almost 60% of them said they had no problems eating. When you talk about cancer patients, is that what you think of, that they're having no problems eating? No. What happened is we actually then asked them all these other things. They checked off. The default was always no problems. But we found that some of these patients who checked off no problems eating ended up having 5 to 7 other nutrition impact symptoms. When I say, are you having problems eating, they may say no. And what they mean is they can chew it, they can swallow it, it stays down, and it stays in. If they're having none of those problems, then they think they're having no problems eating. So I think, again, it's what we're asking. When we looked at the people who had no problems eating, this was the percentage of patients who actually checked off at least one of these things. And as I said, they lots of times checked off anywhere from 3 to 5 to 7 additional symptoms. So if you add 10% here, 4.8% here, and some other things, then all of a sudden you're having a lot of nutrition impact symptoms that are going to mean why they're not taking in a lot, why their appetite's bad, etc. But if the patients who checked off that they were having problems eating, look at this. Even those, about 60% had no appetite. A quarter of them or more had dry mouth. A lot of them had pain. A lot of them had taste changes. So really, and what's the most important part of that? It's not to just say they got lots of symptoms. Okay, you shake your head up and down lots of times. So I'm going to ask you a question. If somebody gives me that checkoff point, see, I did warn you ahead of time I might do that. Somebody does that. What does that checkoff list tell me? It tells me what the problem is. If I know what the problem is, I can do something about it. A lot of patients don't want to complain, don't want to say what the issue is, or they're afraid if they have this symptom, it means their cancer is coming back or not getting better. So again, by asking the question, if I know that they've got mouth sores, I can deal with it. If they never tell me about it, I can't deal with it. So what this does is it actually gives you a roadmap of, as a dietitian or someone in nutrition, to say, I've got to give the nurse a call, I've got to give the physician a call. We now know what the impediment to some of that nutrition is. So that's one of the most important part of this. And we found that if the people handle that box 3, which is the symptom management, if those are controlled, patients don't lots of times lose weight. It's really impactful. So as I said, 60% had no problems eating, but of those, over half checked off at least 1 or more symptoms, sometimes 5 to 7. We're not asking the questions we think we are, and so that's why it can be helpful. And again, this is kind of goes back to what it is once we've got that information, it helps us triage and be able to treat it. ECOG performance status. How many of you have exercise as an important part of your, we won't say everyday life, your students, of your weekly life, that you exercise or ride your bikes or have good activity? And I'm proud of you, because that's not what we necessarily see in the States in college students, because there's a lot more biking here, there's a lot more walking. But the reality is activity is important. And as I mentioned, remember there's a score of 0 to 4. We didn't invent this. This is what oncologists use all the time. It's what they're used to. Some people will use what's called a Karnofsky. I was a surgeon for a lot of years. I like simple things. You know, I can't remember 90 to 100, 78. I like it 0 to 4. I was trained that way. I can get it. I can remember it. So when we take this in the same context, remember it was little impact to potentially life-threatening for the other ones for nutrition. So having an ECOG performance status of 0 means that you have normal activity. 4 means you're bedridden. Again, very easy to figure out. Even if you forget them now, you can remember them very easily. 1 is fairly normal. 2 is less than half of your time in bed or chair. 3 points is more than half of your time in bed or chair. And if you see that, again, most of them, about 73/4 of them, were normal to fairly normal. But you had a number of people who were either bedridden or spending, again, almost 25, a quarter of them were spending a good amount of their time in bed or chair. What's interesting is during World War II and the Vietnam War, there was work being done on conscientious objectors. and actually seeing in World War II, they actually put them in body casts. This was research that you did on conscientious objectors for war. There's ethics issues on that one probably. But there was also I said Vietnam, I meant Korea. They actually did work in terms of just complete bed rest. You didn't have to be in a body cast. And what they found in those people who had complete bed rest for at least a week, that you actually could have up to 4% loss of lean tissue just with complete bed rest alone. Think if you've ever had a cast. What happens when you take the cast off? You have lost a massive amount of muscle. Muscle needs to be moving, needs to be active, needs to have stimulus to actually be able to be maintained. How many cancer patients or COPD patients or other patients who are going through treatment are spending at least a week out of a month in bed? That's 4% loss of muscle mass. And then we wonder why people are fatigued. Okay, clinical assessments. Any questions before I said this was interactive. I made you wave your hands. I've asked a few questions. But are there questions you have before we go beyond that part that the patient was a part of? In the back.
What kind of symptoms can you find in other?
In other patient populations? Okay, let's go back to the question about others. I know, but this way we can see it. There's a reason. I know my slides, guys. So I think it's better to actually see what it is on the tool itself. And so if we look at how it's set up, this one, other, it actually can be any other. Any patient who says, this is keeping, because, I mean, we could have had a list this long, but it wouldn't have fit on 2 pages. So what we did is we wanted to do other, so anything that from their perspective in the last 2 weeks has kept them from eating, we would actually include. What was interesting is originally we did not have fatigue, and we added that subsequently after the original study. Problem swallowing was one that actually I think got added subsequently. But the ones that we included as examples were depression, dental problems, and money. If I've got a head and neck cancer, and a lot of times people will have their teeth taken out prior to radiation therapy so that they don't have problems with a life-threatening infection when they're getting radiation. A lot of times, if I'm not addressing that, dental problems can be an issue. If I'm not getting head and neck radiation, but I have a tooth abscess, you know, it's a poor patient. They haven't seen a dentist in 6 months, and now they're having teeth problems. So it's anything that they think impacts their ability to eat adequately. But again, a lot of people don't think of depression as one that would impact it, which certainly it can. And also money. If I have a choice of buying my pain medication and buying my nutritional supplements, most people would end up going with their pain medication or their oral chemotherapy. So the nutrition lots of times may be something that goes further down. And so it allows us to, if somebody puts money, it allows us to get them involved with the social workers or to get involved with some program that we can get free nutritional supplements, et cetera. So it really is a guideline to let us, but I think that's a good question. Are there other things from your perspective that you think would probably have an impact other than these that you would see might have an impact?
I was thinking about mood, but you already said depression.
Okay. Although, and I think that's a really interesting thing, and probably if you had helped me define this, I actually might have put mood instead of depression. Because I think sometimes people don't want to admit to depression. They have no problems admitting that they may have a blue mood. So one of the things that we've learned is sometimes the choice of the words that we use, but I might do it a little differently if I went back. So, you know, those are the kinds of things that the evolution is helpful. Any other questions before we go on? And don't look so you get dizzy as I'm going forward, sorry. Okay, so who are the people who did the clinician? And one of the things, is that a stretch or a question? Stretch? Okay. I have to talk better so we don't need any of those. Basically, the bottom line is the clinician. One of the things I think is important is in the United States, we call clinicians anybody who clinically is involved in the patient care. So Dietitians are clinicians, nurses are clinicians, physical therapists may be clinicians, anybody. So, but I think in Europe and particularly the Netherlands, lots of times clinician means doctor. So if I say clinicians, I'm not just referring to my kind, I'm referring to all of us who take care of patients. Okay? So who were the people who were the raters who actually were part of we had the 2,150 patients, but we had 55 institutions, but we probably had about 120 different clinicians who were part of this. Over half of them were dietitians, about 40% of nurses. As you can see, the physicians were not well represented in this study, but the others, we had some physical therapists, et cetera. The completion rate of the assessment by the clinician to say whether they agreed with the scoring, et cetera, was about 90%. In terms of completion, some of them didn't do the physical exam because they didn't feel so comfortable. So here's what is, again, this has evolved over the first probably 2 years after we did the study, and we still make some little tweaks based on input. But basically, it has what I call worksheets. Worksheet 1 helps you address the actual scoring of the weight loss. And you can see here is the weight loss in 1 month, weight loss in 6 months, goes 0 to 4. You're seeing a real good trend there, right, to 0 to 4. Bottom line is it makes it so that if it's more weight loss in 1 month, that has greater impact than the same degree of weight loss over a longer period of time. So 5 pounds in 1 month versus 5 pounds in 6 months physiologically is a different thing. One of the things that sometimes people wonder is we said 2, for example, for 1 point, 2 to 2.9. It's actually 2.9999999, but that seemed kind of silly. So it's basically, think of these as whole integers. So anything that's 3 and above gets this number of points, 3 and below get that number of points. Worksheet 2. Is cancer the only thing that is catabolic for patients? No, we've talked about COPD, HIV/AIDS, pulmonary or cardiac cachexia, trauma, broken bones, fistulas. All of those things can actually impact this. Okay? So what we've done there is address it. Now, in terms of the staging, cancers are generally stage 0, 1 to 4. And so, although we don't include that in the score, the reality is if you were going to do a retrospective study and you wanted to know were these patients with metastatic disease or early disease, you actually have that data that you've captured already. Worksheet 3, metabolic demands. What does fever do to your metabolic requirements? Increase it, decrease it, stays the same. Increase it, I think I hear. What's interesting is a fever of going from 1 degree above 34 degrees centigrade actually increases your requirements by about 14%. So if I'm a young man who has non-Hodgkin's lymphoma, I'm on corticosteroids, I'm running high fevers as part of my disease and part of my chemotherapy, and I'm running fevers of 39 degrees, I'm increasing my requirements by about 25%. And I'm not eating probably as well. So it's actually this balance of what I'm taking in and what I'm taking out. So it has a component of fever, how high and how long it has. Corticosteroids. What happens if you're taking prednisone, bless you, see, I'm very attuned to what you guys are doing out there. So if somebody you have some inflammatory process and your doc puts you on prednisone for a week, what's going to happen if you don't increase your protein requirements or you don't have an impact on your nutrition? If I were to do a 24-hour urinary urea nitrogen on you to see how much you're actually losing, would you be losing protein in your urine or losing nitrogen in your urine? We all break down a certain amount of muscle every day, and we rebuild a certain amount of muscle every day. If I take corticosteroids, I have an impact on my ability to redo that. So what happens is prednisone, methylprednisolone, any of the corticosteroids markedly increase your protein needs. And actually, if you're not meeting those needs, you actually are going to start. Does muscle have any storage properties? No. All protein in our body has a role to play. If I don't take calories in, you can't see it behind my podium, but I do have a little excess adipose tissue that I can utilize if I'm not taking adequate calories. What happens to my muscle? If I'm not taking in protein, and I'm not taking in calories, and I don't have that caloric reserve, or I'm doing it all the time, breaking it up and breaking it down and building it up, if I'm not getting protein, I have no stores of protein. It's all functional. The only place I'm going to get that protein that I need for other things besides muscle is to break down my muscle mass. So prednisone is the most common source of pharmacologic breakdown of muscle mass. Physical exam we'll talk a little bit more, but this component of metabolic demand is an important one. So we've gone through these a little bit, so we don't need to address those. One of the things is on prednisone equivalents, and one of the things that a lot of people never asked about it. What do you mean by prednisone equivalents? Although if anybody asked, I'd always send it to them. There just wasn't enough room on 2 pages to put it in there. One of the things is with the apps, we've now got it. You can put in what drug, what volume, what milligrams they're getting, et cetera. We also now have them so that that's on the website and people can actually get them. But this is what we break it down into low, medium, and high dose, each of the different kinds of corticosteroids, and those are the ones that metabolically have similar effects in terms of the protein-losing components. Physical exam, okay. We're going to go through that because I know you know how to do it. This is what's on the PG-SGA. It kind of looks like going to a sushi place where you circle, I want this one, this one, this one. Originally, we did not have this degree of the physical exam. It was a straightforward, subjective. Do they have muscle loss? Do they have fat loss? Do they have excessive fluid? We worked with the American Dietetics Association, now the Academy of Nutrition and Dietetics, and they said, dietitians don't do physical exams. You're going to have to kind of give them a roadmap of what they should be looking at. So we originally put this on this with the work with the American Dietetics Association. I think it's done some really good things, and I think it's done some really bad things. We'll start with the really good things. Dietitians 20 years ago didn't really necessarily think it was their role to be doing physical exam. And when I started saying, you need to do it, it's an important part of doing it, people say, well, if I touch patients, is there liability with that? No. Do you shake hands with them? Well, yeah. Is there liability with it? No. So it was just a mindset. But a lot of people see that and they go, I don't know which muscle, I know what the temporalis is, but I don't know what these different muscles are. I feel very uncomfortable with doing the physical exam this way. So there are some people who just got scared when they saw all this information. The interesting thing is, remember, where did I say most of the scoring is done of the PG-SGA? First 4 boxes, patients do all the work? Okay. This whole score is 3 points, even though it's got all that complication. Okay, I picked on you, and I picked on you, and I picked on you when you stretched. So when you've already said something with, I didn't have to pick on you. Who's willing to answer a question? It's a simple one.
Go ahead. Otherwise I'll pick.
Okay, back there. If you had never been trained on how to do the physical exam, thank you for volunteering, okay? If you had never learned how to do a physical exam, but you're an observant, smart guy who's here at Hanze, so you wouldn't have gotten in if you weren't smart, okay, and I ask you, are you going to get confused by somebody who's had severe muscle loss to somebody who has no muscle loss? You're going to get those two confused probably? Probably not, okay? If I have somebody who has mild muscle loss and somebody who's got severe muscle loss, are you going to probably get those two confused? You can say the same answer again. It's okay. Probably not. Good answer. Okay? If I was going to say mild versus moderate, you might get those confused, right? And moderate to severe. Less likely, but you could get them confused. The difference between mild and moderate or moderate and severe is 1 point. So if you hadn't been eating, you'd had no sleep, you had a beer last night, chances are you're only going to be off by 1 point. So it takes away being scared about doing this physical exam in terms of scoring it. you're not going to be wrong. It's not going to make a difference in the whole score of how this is done. So I think it makes it an important component. So these are the components of what's in the muscle. You'll actually, when you see the PG-SGA, you can see those yourselves. But I think it's important to know that it's important to think about them, but it's not intimidating. It shouldn't be. Yes, ma'am.
I have a question about the prednisone.
About
The prednisone.
the prednisone, yes.
Because my mother-in-law has reuma, how do you say it?
Rheumatoid arthritis? Yes. But I said you could say it in Dutch and we'd get it, not a problem.
Okay, thank you. And she takes a lot of prednisone, and she walks off doing it. But is that only because she uses prednisone, or is that because she is losing protein?
Excellent question. There's actually 3 reasons why people who are on corticosteroids can actually gain weight and actually can fluid retain. One of them is that one of the side effects of corticosteroids is that you do actually fluid retain. But my guess is if you were kind of pointing to your face, that's usually not fluid. One of the hormonal effects is that you can actually, it's where you gain your fat can be very different. So lots of times they'll say it's a moon face. It actually looks very large and round and has a very specific look to it. If you see somebody on the street who looks like that, chances are they're on corticosteroids. So part of it is it changes the fat distribution. Part of it is it actually makes people fluid retain. But in addition, you're extremely right that she's losing a lot of protein because of those corticosteroids. Now, you're second year, right? Okay. So you've still got 2 more years. So if you don't know this answer, that's cool. But the bottom line is, how would you intervene in that person, your mother-in-law, to help her with her muscle mass?
Yeah, I would say she needs to take extra protein.
Perfect. And what else? Remember anabolic competence? Exercise.
Yeah, extra. That's difficult for her because she can't walk.
Okay. Does she move her arms?
A little bit.
Okay. Unfortunately, that can have an upper extremity, but one of the things that person who has problems with activity, etc., needs something else. Activity is important. There are things that you can do with bikes, with TheraBands, exercise bands. So if you were to talk to your mother-in-law and say, there's something you need to do and ask your doctor about, it would probably be to see a physiotherapist. Because those people are experts with that and can give exercises that may actually make her joints more functional, because if you don't use them, they actually get worse. But we'll know which are the ones she can or shouldn't be using. So one of the things I said, you take home something, all of you hopefully, when you leave here. I think when you go back to think about your mother-in-law, you're going to think about making sure that she probably gets 1.5 to 2 times the recommended components of protein, because if she's taking chronic high steroids or even chronic low steroids, that can make a difference. Excellent question. Okay? Thank you for doing it. Okay. Am I going the right direction? I'm not. I knew something didn't look right. Okay. Now, someone who is relatively tall and thin, you know who you are. I need a volunteer, male or female. I see smiles. You don't have to. You can be short and thin. I don't care. Somebody, I need a volunteer. You're going to get applause before and after, so you might as well come. I see a hand back there. Okay. And if you aren't tall and thin or short and thin, that's fine too. Anybody, whoever raised their hand back there, I saw a hand. Yes. Oh, I didn't actually give that. See, I thought he knew what I was saying, so clearly I did not communicate that well. Yes, come up here. Oh, go back to where the plug-in, the electronic thing, or the, yes. Okay, now I want you guys to examine him as he's walking. Okay, now you can come to me. Okay, so what do you notice about this guy? What's your name?
Jeroen.
Jorgen?
Jeroen or Jerome.
Jerome. Okay, I can handle that one. Okay. Jerome, we want you to come over here a little bit. Come over by my table, my examining table. Jerome, you guys know him, yes? You've seen him before? Okay, when he walked down here, how would you describe his walk? Upright. Okay, that's a good one. Okay, did he have high energy or low energy? High energy. Okay, looking at him, is he in reasonable physical shape?
Thanks, guys.
Okay. Yeah, you're reasonable. I didn't say good or bad. I said reasonable physical shape. We're not going to make anybody be too uncomfortable. Okay. Now, I want you to go back to the same place. Oh, no, since we want you to see. Go to that end of the table. Now walk like an 80-year-old patient with cancer. Who's, good question. You choose whichever one you want. But you've lost weight. Lung cancer. Okay. You're 80 years old, lung cancer, you've lost weight, and you're coming in for your first nutritional intervention or referral. How would you walk then?
Probably go down on my knees.
Well, you might be like the man in the first picture who was in a wheelchair.
Yeah.
That could be one. But the other time you'll sometimes see people, this is not me, I actually can do upright, but they might be doing like this, and they're holding on to things as they're going by, and they're huffing and puffing. You would know immediately that that person was in very different shape physiologically than Jerome walking down here. So just watching how people walk down the hall gives you a tremendous, their appearance, how they walk, their carriage, their face, that makes a difference. Now you mentioned your mother-in-law's face. If I saw her, I'd go, this woman's probably on steroids. His face, again, we're going to say, looks reasonably normal, okay? If he was the patient that I just described, had lung cancer, had lost weight, what would his face look like? What would his bones look like in his face? They'd stick out. Where would be the places that we'd look at? Here, the temporal component, under the cheekbones. Those are places that we could see very obviously, very quickly that he'd lost weight. Certainly, if he's lost weight and muscle mass in his face, has he lost at other places? Again, most people don't just lose. It'd be fine if I lost only facial fat, but that doesn't work that way. Okay. Now, I said a lot of times there's not an issue of liability in shaking hands. So I'm a friendly doctor. You're a friendly patient. Jerome, it's great to see you again. Okay.
See you.
Now, who's heard of a hand grip strength, or assessing hand grip as part of a nutritional assessment? Okay. What's he doing? He's gripping my hand. So I can tell something about his hand grip strength just by how he shakes hands. Now, if somebody is, again, my 80-year-old, malnourished, cachectic patient, how would you shake hands?
I can remember from my grandpa, actually. It's very sloppy. And actually the elbow hangs as well, and it's just barely gripped on.
And sometimes it's hard for him even to bring up the arm to be able to do it. And you're not going to give me this good grip, okay? So basically a handshake is the poor man's or poor woman's grip strength assessment. Okay, now there's another one that's very, yes. The man who asked other questions. Yes, go ahead.
I know some people who give sloppy hand and they're healthy.
Sloppy is not the only thing. But the reality is, yes, some people just have kind of wish-wash hands. So that's not the entire thing that we're going to base it on. But you're right. It's the totality of the picture that you get from people. Okay, now I want you all to go like this with your index finger and your thumb. And I want you to push as hard as you can between those two. And then I want you to feel the muscle here, between that, right here in this ridge. What does that feel like? Kind of feels a little bit, if you're really good, kind of feels like a balloon, right? It's got soft, it's got giveness, but it's got some tension in it. Okay, if I'm you at 80 years old with lung cancer, hopefully it's not you, but the man you're representing, I could actually, if I'd lost a lot of muscle mass, what would I feel? Either very poor tone, or I'd feel the underlying bone. Think of some people you've seen with very, very skinny hands. They couldn't do that. And it's actually been shown that this eminence here in the hand is representative of what happens to the total muscle mass. So if this is really poor, unless they have other reasons why they've lost muscle mass in their hand, that tells you what's happening in the patient in general. Okay? Now, so I've shook hands. Now, would you think, nice doctor that I am, if I were going to let you up on my examining table, that I might help you up on the examining table?
I sure hope so.
Okay, especially if you had lost weight. So we're going to have you come up here. Jerome, it's really great to see you again. I'm going to shake it. And what I'm doing is, now people who talk about good manners, turn to the back so they see your back. The appropriate way to shake hands is not to touch people above the elbow. It's just to shake hands. You shouldn't do this, you shouldn't do this. Good manners. We all do it. But if I'm doing this to him as a patient, and I feel here, what am I doing? I'm doing basically an assessment of this triceps skin fold and the muscle mass underneath it. Okay? I can tell if I check him here if he's lost massive amount of muscle, or the fat is just hanging there, or has very poor muscle tone. So now I've done the hand grip strength, I've done triceps skin fold, and I haven't done anything other than being nice and shaking your hand and helped him up onto the exam table. Okay? Now I want you to get up on the exam table all the way.
If you help me down.
As I will help you down. So, another thing, that you can do in a hallway, even if you don't have an exam. You can do all these things, and what you'll see up here is called the sneaky nutritional physical exam. Patient doesn't even know you're doing it. You don't even know I'm really necessarily giving a lecture. You could give this lecture at this point. But there are other things you can do that give you a little more assessment. Now, where's most of his muscle mass? Other than here, we're not talking about that muscle mass. But upper extremities, lower extremities. Lower extremities, exactly. So if I'm going to lose muscle mass, and muscle mass loss is related to the volume of it and the inactivity, where am I going to lose most of my muscle mass? Upper extremity or lower extremity? Pardon me?
Upper.
Anybody else have an idea? Most of my muscle mass is here. I'm sick. I'm spending at least half of my time in bed or chair.
Okay.
Okay. What would the answer be?
Well, then it would be lower.
Lower extremities. Very good. Now, do you talk with your hands?
Most of the time.
Yes? Okay. If you were in bed and spending half of your time in bed or chair, you were losing the muscle mass here, but you were eating.
Oh, yeah.
You were doing the channel surfing. You were moving in and out of bed. We lots of times don't lose muscle mass in the upper part of our body as fast as we lose it in the lower part of our body. What's the biggest thing that patients will complain about other than, say, pain or nausea with a cancer diagnosis or other diagnoses? Fatigue. Lots of times say, oh, it's the chemotherapy, it's because you're not sleeping, it's this or the other thing. The vast majority of physicians don't think about the 4% loss of muscle mass of the patient, even if you're spending at least a week in bed or chair with complete bed rest, or the fact that they've lost a lot of. People can't climb stairs as well. My guess is probably your mother-in-law has problems with stairs and getting up and down in the chair. Most of her rheumatoid arthritis is in her hands, probably in her upper extremities. But where she's having problems with function lots of times is the lower part, because people are losing it here. So what's a very easy way for me to assess his muscle status as he's sitting here on the exam? Oh, one other thing I forgot to do. Here, I've helped him up. You were wondering about that. Okay. Here, what happens if I put my hands here and I'm just talking to him? It seems like I'm a really nice talking doctor. Mutually exclusive sometimes. So a really nice talking doctor. What am I feeling on his back? The ribs, the loss of muscle around his scapula. I can be doing this. Now, one other thing. You had mentioned your mother-in-law has a lot of fluid retention. Okay? Another place, if you're in the hospital, say you got admitted, or I saw you walking down the hall and I saw you had a lot of fluid in your lower extremities. And then I brought you into the hospital for something. Or I told you to go home and go to bed. And what would I tell you to do? I'd tell you to elevate your feet. What happens to the fluid in your feet? It gets better, right? That's the whole reason we tell you to elevate your feet. Where does that fluid go? Let's think I put him in the hospital. His head's like this because he's in a hospital bed, and his feet are like this because I've told him to elevate his feet. You're pointing somewhere. Where is this fluid going? No. His butt, right above his presacral area. I normally ask, can I touch you? It's a little late, but okay. You did volunteer, right? So if you want to look for presacral edema, lots of times where people will, it's just a matter of gravity, and what will happen, they come down. And a lot of times, if you actually check a patient who came in with fluid retention, and you check the presacral edema, now this is not like shaking hands. This is probably more likely nurses and doctors, but it may happen. Or you'll see it, or patients may complain that they've got a lot, it just doesn't feel right there. And a lot of times you can have a lot of fluid that just ends up going in that presacral area. Again, if they're in the bed in the hospital with feet up and head up, okay? So we've now done all the aspects of muscle mass and thin. We've looked at whether we've lost muscle mass and whether we feel his skeletal components in his back. Other things that now, those were more invasive, less invasive. What can I do to actually see in his upper extremity or lower extremity in terms of his muscle function? I've checked tone, good or bad, okay. He's got, I'm sorry?
Maybe resistance?
Yes. So if I say, and a lot of doctors do this for a neurologic exam, but they'll say, I want you to push, make a fist, and push against me as hard as you can, and don't let me do this, okay? Now, he's pushing against me. I'm not really pushing that hard, but, you know. But if you were the 80-year-old cancer patient, and I pushed this, what would happen?
Well,
The resistance would probably not be nearly as much. He might be able to do it, but it might be the back and forth kind of thing that he's doing. But we can do it pushing, we can do it pulling. So that will tell us different muscle groups that we're looking at. But again, where's most of our muscle located? Lower extremities. So I can do the exact same thing of having here, you don't have to make a fist on this one, doesn't help. But if you want to, I'm going to pull your leg out, and I want you to pull it back down and fight me if I'm going this way, or if I want to go this way and you want to push it. So again, think of where we're going to have this greatest muscle mass is here, and this is part of assessing that. Okay? So that took a little longer because you were fun and they asked questions. But normally I can do this physical exam, lecture, and tell you how to do this basically in 3 minutes. If I can give a lecture and a physical exam in 3 minutes, can you do this in the hallway or in the exam room if you're talking to a patient? And it's what's a sneaky physical exam. But my guess is next time you see a patient walking down the hallway, you'll be doing your sneaky physical exam because it's such an easy thing to do. Is there anything else about the physical exam that we could do as part of that sneakiness? If that's all I did, do you think I would have a better sense of between mild and moderate and severe? Again, I'd probably still only be off by a point, even if I was wrong, but you can get a lot more information. So, Jerome, thank you.
Thank you.
Round of applause. So now we've done the entire PG-SGA. We've talked about the triage. The only place that we ended up making much of a difference in our assessment was we went 2 to 3 for this second one. Other than that, everybody agreed with our assessment. There is a subjective global assessment that is well-nourished, moderate, or suspected of malnutrition, or severe malnutrition. And what we've done is taken the components that were part of the original SGA and put them as the PG-SGA and done assessment categories. So basically in our clinicians, as I mentioned, they basically agreed with most of them except for the 3 to 8, and that's why we put the score a little bit differently. This is how we've actually done an algorithm to address that correlation between the SGA and the PG-SGA so that we could actually put it in our app. One of the things that's different between that original SGA was it was a categorical assessment. You had to be A, B, or C. They talked about physiologically well-nourished, moderate or suspected malnutrition, or C being severely malnourished. Again, my concept of anabolic competence. A, again, remember I'm an ex-surgeon. I like things simple. What does A stand for? Anabolic. What does C stand for? Catabolic. So what does B stand for? Between. I mean, it's something, you know, but it's a very easy way of remembering what the A, B, and C stand for. The nice thing about the PG-SGA is it's a continuous measure. So I can go from 0 to 39 points. And it tells me it's going to take a big leap for me to go from severely to moderately malnourished. As a patient or as a physician or as a dietitian, for me to have a patient going from 29 points to 19 points to 9 points is something that the patient can relate to. I can know I'm making progress. It's basically a snapshot of what that patient is when I'm seeing them in the clinic. So that's one of the other strengths of this. It tells me what to look at, how to intervene, and it gives something the patient particularly, since it's an empowering component, to know what they're doing and how they're changing it. One of the things that was interesting is that when we asked the clinicians, again, remember, 52% of these were dietitians, 40% were nurses. These are all people who should know something about whether their patients are at risk for nutrition or not, or have malnutrition. What we found is at the end is we said, did this change your perception of basically treatable nutritional risk with your patients? And a third of them said yes. We actually had, which is really kind of surprising when you think about it, but it says the power of the tool. What was interesting is we actually had a presentation yesterday with some of the fourth-year students, and one of them did an assessment using the short form, the first 4 boxes of the PG-SGA, and they actually found in the patients a third of them had an understanding of their nutritional risk or deficit by doing it. So it really has an impact on both the patient, of empowering them and saying this is important and this is what you need to do, as well as the clinicians. Okay, I'm not going to try and say that. You say that because I know you know how to say it. So maybe next time I'm here I'll learn how to say that. But I know what it means. So remember I said you were going to do a nutritional assessment of patients before you left today. So if these 3 people walked into your clinic, which of them would you say was malnourished? All? None? 1, 2, or 3? All of them are malnourished. Okay? Would you do anything differently between the 3 of them? First thing, since we're talking about the PG-SGA, maybe let's do a PG-SGA on them. See what the score is. So patient 1 in boxes, the short form, boxes 1 through 4, has a score of 16 points. Patient 2, boxes 1 through 4, has a score of 4 points. Patient 3 has a score of 16 points. Now think of your standard doctor, and I don't mean to pick on doctors, but doctors don't lots of times have nutrition as part of their training. I'm a doctor, so I can actually do it. I mean, I can say that some doctors don't. So this patient here has a score of 16 points, and this patient here is. Do you think most physicians would see those patients in the same way? Absolutely not. How the heck can this woman, who looks really very similar to this man, how can she have such a low score? Should we actually go through the scoring to see if it helps you understand that? And again, score above 9 is somebody who there is a critical need for intervention, whether it's symptom management, dietitian, or some other intervention. Let's look at this man. Remember I had you do that muscle thing between the index finger? Clearly, you can see. Remember I said you'd feel bone underneath? This is a man who's not going to have that soft and squishy, but with some tension in that component. When you look at him on his physical exam, what kinds of things do you see? Remember we talked about his face. You certainly see it there. You can see his scapula. If you wanted to study the anatomy of muscles, You could probably do it because you can see where all of them end and begin in his neck. There's a squaring here of his shoulders because he's lost the muscle mass around the shoulders, so this is called squaring of the shoulders. You can see he's literally skin and bones here. You can see the muscle mass loss here. He actually has a central line. I placed that central line so I know that's what that bandage represents. But clearly, any of you would say this is a man who's probably either at very high nutritional risk or malnourished. I gave this talk to a group of physicians once, and there was a neurosurgeon sitting about where you are. He said, Faith, you look at everybody from a nutritional status. This is just what little old people look like. Which says he sees a lot of geriatric malnutrition that he just doesn't see at all. So let's go through it. He previously weighed 65.9 kilograms. And I'm going to do my English cheat sheet here so I remember them correctly. So his current weight, is 65.9. What he was previously, in 1 month ago, he was 72.7 kilograms. He didn't have his weight 6 months ago, and he's lost weight during the last 2 weeks. So the maximum score that you can have here is 1 point for this and up to 4 points for this. So his maximum is 5, so he gets 4 out of 5 points there. Now, one of the things that's important to know about this, and again, it's that the phrase, I don't know if you have it in Dutch, it's better to be lucky than good. Well, we were lucky. The scores on this side are additive. The scores on this side are whatever is the top score. So you can see he checked off here that his intake is unchanged. He's over 65. He took very little of anything. So his score, even though he did something here and here, even if he went down and checked 3 of these things, it's whatever's the highest score, so he gets 4 points there. His symptoms, he's got no appetite, he's got nausea, constipation, he's got 5 points there. And his ECOG or WHO performance status is an ECOG 3. One of the things you'll notice is there's a 3 points here and a 3 points here. You can be at bed rest for reasons other than inactivity. You may have just had surgery or whatever, so there may be reasons why the person can't get out. So these actually normally would be a 3 and a 4, but because of this, we actually just have a 3. So he gets a maximum score there. So that's why he's got 16 points. Ready for the next person who only has 4 points. How can that possibly be? Okay? If we look at her from that standpoint, why does she have a black line across her waist? There must be a reason that I put that there, right? If you want to address muscle loss that's predominantly nutrition, look at the upper extremities. If you want to look at muscle loss that is a combination of inactivity and nutrition, you look below the waist. So if you're trying to look at isolating what's nutritional muscle loss, it's probably looking at the upper extremities. Kind of like what we were talking with Jerome. Now, what can you tell me about the physical exam on this person, just looking at her? Again, you guys don't do physical exams, but I'm making you do it, and you're going to get right answers. What about her hands? What can you tell me about her hands? They look really big, don't they? It's because I can't make my bones in my hands any smaller. So if you see very malnourished people, they look like their hands are disproportionate to their size. So it says she's lost a lot of muscle mass, which you can see in other places. Okay? She's got a central line. So since I'm giving a nutrition talk, let's assume that it's parenteral nutrition. Okay? What about this bag here? It's an ileostomy, because it's on the right side of her body, so we'll say it's an ileostomy. Or it could be a very low colostomy, but it's functioning. It's got fluid in there, right? So she's probably not obstructed, so that's working. What do you see about this kind of diamond-shaped thing here? Kind of stippled. I don't know what's stippled in Dutch. It's kind of got patterns here. You can see it's got, it looks like it's kind of slowly healed in different ways. It's not an even pattern. But what about this little black thing here? This was a large abdominal wound. All there is left to heal is this little black area. Could she have healed that if she wasn't anabolic? So clearly, that person that I did before, who was my patient, was clearly catabolic and going downhill. This woman is anabolic. Things are functioning. She's getting nutritional intake. She's healing wounds. Her GI tract is functioning. So let's go through her component. Okay? Her current weight is 47.7 kilograms. She actually was previously 45.5, so she's actually gained weight, right? Last 2 weeks, it's been unchanged. So she gets 0 points there. When she says that her weight, that her aspects of her intake over the last month has been unchanged because she's actually been getting her TPN. And she's taking very little of anything, but it's actually in terms of she's getting it by vein. So she gets 0 points there. Now some people say, well, if she's on TPN or tube feedings, why isn't she getting points for that? That's going to be only liquids. But if you're meeting their requirements, that's not a risk factor. Whether I get 100% of my calories and protein by mouth, by tube feedings, or by vein, the body's pretty much seeing it as a similar amount of meeting my requirements. Now, if somebody's getting tube feedings and you tell them they need 6 cans of whatever your choice is, and they're only taking 3 cans, do they get 0 points for their tube feedings? No, because at that point they're not meeting their requirements, and you would probably put them as taking only liquids, and they'd get the 3 points for that. So that's kind of how you are able to do that. Now, in terms of her, basically she says she really has no appetite. Now, it's very hard with a name like Faith to lie. This is not my patient, so I can't tell you what she was doing. Okay, full disclaimer. But I have had 2 patients like this, one of whom who worked as a traveling salesperson actually took her TPN on the road with her. She put it in a cooler, she put it in the plane. She was all over the world because of taking her TPN with her. Another woman who I first met was 5'4", weighed 67 pounds when I first met her. Lived with multiple recurrences and other things down the road over. She was actually in her very early 30s and had 3 young kids. She was able to never eat through. She had multiple surgeries. She had short gut, very bad malabsorption. She would occasionally eat for fun or with her family, but it would go right through her. She was totally dependent on parenteral nutrition. Okay? She lived another 10 years. She raised her family. So from my perspective, I say this is a woman who didn't have cycled TPN, so she had no appetite because she was just getting her calories all the time. So cycling TPN is a really important way of getting people to get off of TPN or to actually have some appetite and feel better. But naming those 2 people, I'm saying it's fairly normal activity. They were able to do the things, have Thanksgiving. This woman would actually make Thanksgiving dinner for people, for her kids. She couldn't eat it, but she did it. So now do you understand why these 2 people who can look very similar can be physiologically very, very different in how the PG-SGA allows you to get that snapshot. Any questions on this one? I must have seen, no, that hand was going to go up. Go ahead. Mm-hmm. Excellent question, and that's where I may have gone over that too quickly. When we first started giving parenteral nutrition years and years ago, and some people who don't do a lot of it still do it, they give it 24 hours a day, so there's really no appetite because they're always getting calories and protein. If somebody is getting it during, say they're only getting it at night, okay, when they're in bed, but when they're up and around doing work or raising kids or whatever, they're not on it. So just like you and I, if we haven't eaten in 12 hours, might still get hungry even if we've met our caloric intake. So if I wanted to get you off of your TPN, said, I think we're going to start slowing down the amount that I'm giving you, and so that you can start eating more because now your guts have healed and whatever reason that we were on were there. The way I'm going to do it is to make sure that you're only getting it for maybe 8 to 12 hours a day, and that maybe I start slowly decreasing. But because she was getting it 24 hours a day, not cycled, she didn't have an appetite. So you're exactly right. It was because of the TPN, and probably because the TPN wasn't being given in probably the optimal way. Okay? Otherwise, she'd only have 0 points. That would be even more freaky, and you wouldn't believe that at all if I put that one up. Okay, this person. What kind of cancer do you think this woman might have? We talked about one of them before. And that's breast cancer. People can actually, it can be a postmenopausal, can be a risk factor, but in addition, it can also be, people may actually gain weight after the diagnosis. In her case, this is, we'll say, is an ovarian patient, because a lot of GYN oncology patients also, obesity is a risk factor. So this may be how she started. So she's starting out, some people say she's in very good nutritional status. She has lots of reserve. Okay. Where is fat a reserve as a good thing? If I go up to the North Pole and I forgot my coat, okay, it gives me calorie source, it gives me warmth. There are a lot of things that's really the only great thing about having extra fat. Is there a reserve of muscle mass? No. If this woman quits being able to eat, is not able to do it, and she's losing fat, and she's losing weight, and her doctor sees her and says, you know, she had plenty of reserve, it's okay if she loses it. She can lose 20%. Not a problem, she has too much to begin with. That physician has no concept of what he or she is saying, because they're losing muscle mass. And one of the things we talk about when we see someone who has this body habitus and is losing muscle mass, there's a fancy term for that. Anybody have any idea of what it is? It's called sarcopenic obesity. Like sarcomeres are in the muscles, so sarco having to do with muscle, penia meaning small. So this person can be having lots and lots of fat and maybe severely cachectic and have severe muscle loss. And maybe having problems climbing chairs, climbing stairs, getting out of chair, etc. Is obviously going to be fatigued. So in her case, she's currently 95.9. 211 pounds. She's 5'4" tall, clearly in the obese category. She doesn't have a weight 1 month ago. She has one at 6 months, and that was 113.6 kilograms. Now, what if I had both of these each had only a 1 month or a 6 month weight? What happens if they have a 1 month and a 6 month weight? Which one do I use? Because I can't use both of them. Which would make sense to use? Perfect answer. And the reason why is, for example, if I had lost 50 pounds 6 months ago, now I asked how much in the last month, and I'd lost, my weight was 1 pound less. That says that I slowed down my weight loss. Maybe it's because I went to see a dietitian and they've been very successful in getting me to slow my weight loss. Maybe I've gotten over my post-operative thing and I've gone out of that catabolic setting to an anabolic setting. So yes, if you have a choice of two, you take the 1 month. If I have a 1 month and a 2 weeks, which one or both do I use? Both. Okay, it tells me acutely what's going on. Okay, in terms of this component, so she gets 4 points there. She basically is taking normal food, but not normal amounts, so less than normal, so she gets 1 point there. Now remember, this is the first time, I didn't mention it, but it's the first time she's actually being seen. She has no appetite, she has nausea, things taste funny. What's the most common taste change that patients who are on chemotherapy, particularly cisplatin or carboplatin chemotherapy, any idea? Perfect answer, okay? And what happens is, where does that metallic taste come from? Is it the food that tastes metallic?
Yeah, the thing they use to eat.
It's actually probably not the food. It's actually, you're exactly right. He gets lots of brownie points today. Do you have brownie points here? Whatever good points that you have in Dutch, we call them brownie points. But yes, you get good points. Because what's interesting is it's actually the utensils, the food or the spoon, the fork or the spoon that they put in their mouth. Although one time I was giving a talk in Indiana and I said, what's causing it? And people were eating, it was over a dinner meal, and every single one of them put They took their fork on their cake and they put it upside down. I think this is Indiana. They must eat upside down. I've never seen any place else above it. But if you actually say, take your utensil and put food in your mouth, it's actually the metal utensil that hits the tongue, and they're actually picking it up there. And cisplatin actually decreases the threshold, increases your sensitivity to the taste of metallic. So if you've got a patient who's complaining food tastes metallic, what do? You can use plastic spoons or forks. You can actually tell them to pick it up with their hands. Again, asking the right question lets you know how to intervene with that patient. Okay? Now, this person has 9 points here. Her ECOG performance status is 2 points. Okay, she's spending less than half of her time in bed or chair. If I were going to intervene as a dietitian or a nutrition trainee, student, what would I intervene with? Where can I go to make a difference while the patient's in the clinic? This is where most of her score is. This is where I can intervene. Okay? So that's the kind of thing that literally gives you a map of how to deal with it. Okay? In fact, if she's not malnourished now, and let's say everything else, she hadn't lost any weight, she hadn't had any problems eating, she had a good performance test, those would all be zeros. What would her score be? 9. What would the triage by the PG-SGA tell you she needed? Critical intervention with symptom management or nutritional intervention. Because if she is an A right now, in a month she's going to be a B or a C if I don't address those things. So it really tells you what to do. Now, key messages. It's a 4-in-1 instrument. Allows you to do screening, assessment, intervention triage, and outcomes monitoring. It's highly sensitive and specific. We'll talk about that. It's predictive of both adverse outcomes as well as improved outcomes. The time-consuming aspects are completed by the patient. Have any of you, by second year, do you guys have interactions with patients? Okay. When you've been to, any of you have been to a physician with a family member, and the nurses are asking questions, or the dietitians are asking questions, how much of the time is spent asking questions, and how much of the time is spent talking to the patient, telling them how to help? 80-20? Most of the time asking questions and just filling out forms. If the patient walks in and they fill this out and they know, I know what their problem is, instead of asking 50 questions, I can say, I noticed you checked off this and this. This is how we're going to address it. So the quality of time that you're spending with the patient is markedly improved. Okay? Empowers both the patients and the professionals. It's easy to use after adequate training. Can you see that if I turned you loose in the clinic tomorrow, do you think you could actually help a patient work with the PG-SGA? Would you have a better sense of how to do it now than before walking in this room? Okay. And then it streamlines the clinical process. If the patient's filling it out before I see them and I come in and I see what their answers is, I've already saved time. So for people who tell me it takes too long to do it, I'm saying then you're not having the patient fill it out. You're probably doing it yourself. This is originally developed for the oncology setting. Dr. Eisenring's actually going to be here next week from Australia. She works with Judy Bauer. I did the initial work with my colleagues in '96. But we've had it in a number of other settings with elderly, with HIV and nephrology. There are a number of people who are using this across different things. So if you want the full bibliography, as I mentioned before. One of the things, these next few slides, because I want to give you adequate time, although it's been very much a give and take, there's a lot of research that's coming out of the Hanze. This was done in the study in 2013, presented at ESPN in 2014 by someone who I guess is professor, or is a teacher, instructor for some of you, and that is Martine Seeley. But addresses that the PG-SGA, the short form, covers all the domains of Aspen and ESPN's nutrient balance, body composition, body area, and body function. This looks at all of the different tools that can be looked at, and some meet all of those, others do not. The PG-SGA is actually able to predict clinical outcome. This was, again, by Judy Bauer and her group in Australia. It actually was able to predict what the readmission rate within 30 days was. In the United States, if you have a diagnosis, you're readmitted in 30 days with the same diagnosis, the hospital doesn't get paid. So this is the kind of thing, because obviously they let them out too early, or they didn't do a good job of taking care of it. So that was back in 2002. Subsequent to then, we've actually looked at, this is work that I did with an oral anabolic steroid, looking at the PG-SGA score and predictability of hospitalization, almost a linear component. This was in cancer patients getting chemotherapy. So readmission rates, median lengths of stay, survival, quality of life changes are all predicted by this assessment tool that a lot of people will just think about as nutrition. We're not going to go through this other than this is by Vigano et al. Out of McGill University in 2014. Basically goes through a number of things that people will address. The body mass index, DEXA scans, looking at sarcopenia scales, hand grip strength, and actually found good correlations with all of these things that cost money. This paper version costs nothing, and you can actually do it in any of your patients. Also predictability in terms of hospitalization rate, ability to complete cycles of chemotherapy, etc. Looking at quality of life in both the short form and the full form is predictable. Most important thing for oncologists is whether you make a difference in survival. And a lot of times I've heard oncologists say, well, the only way I'm going to get their nutritional status to get better is if I'm successful with their chemotherapy or their radiation therapy. But if you look at baseline nutritional effects, bottom line is survival is worse for the people who have the triage of greater than 9, looking at the short form of 8, or in terms of the lower ones. So clearly, these people live longer if their score is based on the triage. This was the first language version in 1999 with Swedish, and clearly found the same impact. This score, this survival difference, if this was in a chemotherapy in an oncology journal, people would be going, I was going to say something else, darn, that's good. Okay? The reality is we don't even see this kind of impact in terms of chemotherapy or radiation therapy. Much of the work that's being done currently at Hanze is actually looking at the short form, the first 4 boxes versus the full version. This was actually done by Gabrielson in 2013, basically looking at this comparison of the short form and the full form in terms of the ability for the triage to define well-nourished or malnourished. This is the MUST, which actually has 3 questions looking at weight loss and loss of appetite, and clearly doesn't come anywhere close, either the short form or the full version. This just explains a little bit more. Sensitivity and specificity. Important things when you're looking for research or whether it's a tool to use. Short form, 94% sensitivity, 78% specificity. PG-SGA full form, slightly better, but still very close. The MUST, which is what was validated in an acute setting, healthy people, but it's used in a lot of other settings. Sensitivity much lower, specificity much lower, and the AUC of whether it's defining it is much different. This was yesterday. I actually listened to 9 presentations here. 7 out of the 9, if I remember correctly, were directly related with the PG-SGA and the short form PG-SGA. You all are doing, as an institution, doing some amazing things. When we were done, I said, this data's got to get into abstracts and publications. So there's some very exciting things that are going on. Hopefully we'll even get one of them perhaps as a late breaker or another subsequent soon to be a meeting. December a year ago is when I was first here. We actually had, was it Malnutrition Day, December 11th? I was asked to talk here, and it was during the time that we were first talking about the aspect of doing the app and really getting it started. 6 months later, we were walking back from Hanze. We saw a double rainbow, always a very fortuitous sign. It was also the period of time that I was here in June for the first time, and it was actually when we actually launched the PG-SGA or the PT Global app. And interestingly, you are part of the celebration. This week is the 1-year anniversary or birthday of the PT Global app and our website. So you're participating in that. thank you. That was very nice. We're now working on our multilingual. I think the fact that we've got such an increase in the data on the short form coming out, particularly from Hanze, is very exciting. The special thanks are the people here. In addition, the 55 sites where we had people doing it. And this is really, I hope, something you got of. And I actually appreciate the fact of the applause, because I hope sometime in the future, those of you who are second year, when I come back in 2 years and I'm listening to other presentations from fourth years, I think there were a couple of third years. We actually had a couple of nurses. But the reality is, maybe one of your pictures will be here, and you will be someone who's actually helped us further some of the database, the research, the use of it. So thank you very much, and I've really enjoyed this. And happy birthday to the Hanze and what they've done here.
Well, again, thank you very much for your excellent lecture. I think it was a great inspiration for all of you. We have a few more minutes before we close this lecture. You have all prepared your homework. I've seen that. We have gone through it. And there were some very interesting and good questions. There have already been very good questions. But I think some questions are not addressed yet. So I would like to invite someone who had a question and can still ask this question. Yes, go ahead.
What's the actual added value of making this into an app?
Oh, excellent question. Why an app versus just a paper version? Mm-hmm. I think there's advantages to both. I think one of the great things about the app is, for a lot of places, there are institutions actually where now the nurses and doctors and dietitians actually carry around a tablet. And so they can actually they're taking in information as they're doing it. The second thing is that, again, patients, whether they're the 80-year-old lung cancer patients or other people, a lot of them have smartphones. And if they've got a big smartphone, they can actually be doing this on the smartphone or on the tablet. The most important reason is not just that that's the new way of doing things, but the fact of two components. One, if you score it, and I score it, we're probably going to be exactly the same on the score for the first 4 boxes, because those are straightforward. The things on the back with the professional component, there's a number of nuances. They can be high in this, low in this, and the algorithm in the back has to take all of those into consideration. So if we're doing this in the context of research, it actually takes away that inter-observer variability that's so important in terms of a validated tool. The other thing is that, as I mentioned, there are some people who are interested in putting this into the electronic medical record. And so we're working with some pilot ideas in terms of being able to do that, so that it clearly could be, in terms of outcomes-based research, really understand it could almost be real-time data collection in a way that can be very helpful. Now, there are places where money may be an issue. We go back to the depression and money for nutritional supplements. The same thing can happen here. There may not be an ability to have every clinic have a laptop or a tablet. We've actually now have it available also as a web-based one, so if they happen to have a computer in the clinic, patients can go directly on and do it that way, and you still have that ability. So it's an app in not quite exactly the same way. There are also places for very poor places, for example, in Africa or in other places where the monetary component, that the paper version may actually be the way to go for some places. So we're not saying one exclusive to the other, but that it's basically making the opportunities for research, for outcomes based on clinical components, to actually be a part of it. Can you see a downside or an upside for either one of them that made you ask the question?
Yeah, I felt like having people do stuff on the tablet takes away a bit of the social aspect. Like, instead of filling the paper with someone, especially for older people, doing it on the screen, it takes away human interaction.
Now, did you notice what I did in asking that? I said there was a reason why he asked that question. Now I'm going to turn that back and tell you why you don't necessarily lose that. If I'm filling it out in the form, but I would never have guessed this without asking, so it's why it's important to do. When we actually do it, we actually have it comes out, the patient fills it out. They're having the interactive component, but as soon as it gets done, they hand it back to the clinician. The clinician then fills out their part, and it gets sent immediately, or they can do it right in the clinic without sending it to an email. They can actually go through, and it actually has a picture of what are the things at risk, what are the things can do, and so it actually becomes, they can also say, I've noticed that you've looked at this, this, and this, let's talk about it. So it doesn't actually necessarily lose that interactive. The one place it does is, again, there are places that actually are having patients fill this out once a week, once a month, and sending it to their clinician. So it allows them to fill it out, have them think about it, doing it, but then to have the nurse or the dietitian call back and say, I'm still seeing that you're having problems. So you don't necessarily lose that interaction, but I understand I can see how you could see it that way.
I think
Other comments you would say?
No, I fully agree on that. And the interaction, you will mainly use it, like you already explained, for the advice. So you gain time to spend on interaction in helping the patient instead of asking the questions. That's already been done.
And I think that works whether it's the paper or the app.
Yeah.
I think from our standpoint, where it's really important is the research and the outcomes based. But there are some young, people who are coming up in any of the interdisciplinary components that really like the apps, and in the States there are a lot of places that actually use that component. We also know the University of Pennsylvania actually has patient kiosks. When they come in, they sit down, they fill out all their stuff on a kiosk, and then that immediately gets sent to the physician or the nurse or the dietitian. So it's actually speeding up, again, the healthcare component, so that the other thing is everybody can then utilize it.
I have one last question to you as a group. One of the questions of the homework was also to compare the PG-SGA short form to other screening tools, like the SNAC and the MUST. And when we mentioned the MUST in the slides, it's another MUST, it's the MST. We mentioned the MUST in the assignment. Can anyone give a short impression of what came into your mind? What is the big difference between the PG-SGA short form and the other tools?
It's patient generated, and that's the biggest difference, I guess, because all the other forms are filled in by the nutritionist or the doctor or whatever.
And what is your perspective on that?
Well, I've mixed feelings because patient is always subjective, so it's always guessing if they put it in the right way. But on the other hand, it gives you more time to look it over, and it's always a check. If you discuss it with your patient, you're also looking at the data. So, I think it's a better way.
Okay.
There's one other thing, can I add to that? And that's the fact that one of the reasons that we think the multilingual is so important is again, one of the examples I've always used is if I happen to know, even if I know the Korean word for diarrhea, and you're an 80, I keep picking on 80-year-old men, maybe because that's where my dad is, but an 80-year-old Korean man, even if I knew the right word for diarrhea, chances are if I, as a woman, especially when I was a younger woman, asked you if you have diarrhea, culturally, you might never admit to that. So the nice thing about having it in the language and in the way that the patient fills out, people are much more forthcoming because they don't see it as anything bad. They're just, yeah, I have that, I have that, I have that. I've also had family members say, oh, no, you don't have the problem. Who knows better than the patient whether they have the problem? The family member, the nurse, the physician. It's the patient. And so that's the other thing. We get more valid information. And you can always ask. It doesn't mean that you have to accept what they say, but if they've checked off 2 out of 8 things, you're going to focus on the 2 that they did check off.
Yeah. Well, I think we there are many more questions to discuss, but we have to close the lecture. If anyone has any questions, you can always email Faith or me at the info@ptglobal.org email address.